Hello, everyone. My name is John Lyons. Welcome to the inaugural event kicking off the creation of eQIP, which is a virtual partnership to support qualified individuals. As you know, the Families First legislation created the role of qualified individuals to support good decision-making about the use of residential treatment for children and youth. And when done well, actually, the QI can represent an important voice to ensure that young people get the care that they need. And of course, when not done necessarily well, then it runs the risk of becoming a bottleneck and just one more adult that potentially re-traumatize people by making them tell their story over again in a system where people have to tell their story far too often. So we decided, since the CANS is the most commonly used tool to support decision-making within the Qualified Individuals Program, that we had a responsibility to try and help people to be as effective as possible. So that's the origin story of eQIP. Welcome to the partnership. We hope that you get involved and participate, because in our experience, you learn more from each others than you do from anybody else. So let me introduce you to Dr. April Fernando, who's going to host our first live event in support of QIs. Hello, April.
Hi, John. Thanks so much. I'm really excited to be here and be part of this new initiative. The role of the qualified individual is really crucial in helping us decide what care is in the best interests of any given child or youth. We're really excited for this new partnership because we know QIs could benefit from having a forum to learn from each other and grow professionally in this key role. We're going to have many, many ways for them to interact within the partnership, including live events like this one, recorded videos, tutorials, blog posts, tip sheets, and connecting with other QIs, which is pretty important. So please see the description below and visit us at eqipartnership.org. You're going to hear more about eQIP throughout this presentation. But without further ado, I would like to welcome our special guest today, Dr. Christopher Bellonci, Assistant Professor at Harvard Medical School and Senior Policy Advisor at Baker Children's Center. With more than 30 years experience as a board-certified child, adolescent, and adult psychiatrist, Dr. Bellonci works with children, families in outpatient and inpatient and residential settings. He's consulted with state and federal child welfare and mental health agencies, helping them develop best practices and improve service systems. His expertise led to congressional testimony, and he recently advised the Senate Finance Committee regarding the Family First Prevention Services Act, or FFPSA. You can read more of his bio in the description below. All right. Thanks for being with us today, Dr. Bellonci.
Oh, it's my pleasure. I'm excited to have this conversation.
Awesome. As the title of our event today hints to, I believe you were in the room when FFPSA, the Qualified Residential Treatment Programs, and the Qualified Individual role was discussed. I wonder if you could start us off by sharing that story.
Sure. So as you mentioned in the intro, I'm a child and adolescent psychiatrist, and I worked in residential settings for a significant part of my career, over 20 years. I was medical director at a program outside of Boston called Walker. And through that role, I became interested in the role of residential in children's systems of care. I had worked with the Child Welfare League and was on their mental health advisory board. And I also became active in the Association of Children's Residential Centers, now called the Association of Children's Residential and Community Services. And I was actually president of ACRC when I learned that there was legislation being discussed at the federal level that was going to significantly impact young people and the federal support for residential treatment. And so I was invited to present on those concerns at a meeting at the Child Welfare League. And at the time, the discussion was potentially limiting federal support or eliminating federal support for children placed in residential settings below the age of 13. having a 1-year limit for adolescents and a 3-year limit for foster care support for young people. And that had me concerned. The program I worked in was serving young people from the age of 5 to 13. And we were, definitely a tertiary care setting, meaning many things had been tried for these young people, including community-based options. Most of those children would come after several psychiatric hospitalizations. I had a young woman who needed a heart transplant, and she wasn't going to get the heart transplant unless there was a medical home, and there were no foster homes that were willing to take her post-transplant. So, in some cases, these were life or death situations. And so I started talking about that at this Child Welfare League meeting and learned that some of the staffers from the Senate Finance Committee, where this legislation was being proposed, were in the room. And so following my presentation, one of the staffers that was attached to Orrin Hatch's office came up and spoke. And she basically tried to argue some of the points that I had made about some of the young people who would be specifically impacted by the proposed legislation at the time. And that led to a really rich back and forth, because nobody else in the room was challenging her. And so I kept raising my hand and saying, well,
Nice.
actually, and after that presentation, I went up and introduced myself to the staffer. And then she followed up with a testimony from a young person who regretted that she had been placed in residential treatment, and it was around the capacity of the kinship provider having enough bedroom space. And she said, this is ridiculous. And I said, of course it's ridiculous. That shouldn't have happened. And then I sent her some testimony about young people who felt like they benefited from residential treatment. And then eventually she invited me to actually talk with her directly. And so it was myself and the Democratic lead staffer and the Republican lead staffer in the Senate Finance Committee chambers hashing out what became the Family First Prevention Services Act. And I was less involved in the prevention side, but really more involved in talking about the role of residential and what became the Qualified Residential Treatment Program specifics. So that was why I became involved. I really wanted to engage in the discussion that I felt like was going to have a huge impact on the role of residential treatment in that larger service array.
Wow, that's great. It's a great story of being in the right place in the right time and someone overhearing you talking. That's great. If you've just joined us, you're joining the eQIP inaugural event, and we're talking about FFPSA and the qualified individual's role with Dr. Christopher Bellonci, who's an assistant professor at Harvard Medical School and senior policy advisor at Baker Children's Center. So Dr. Bellonci, can you talk more about what distinguishes a qualified residential treatment program, a QRTP, from other types of residential treatment centers so that we can understand the difference?
Yeah, I mean, one of the things that I became aware of when I was talking with the policymakers was that there was, I believe, a lot of misperceptions about just what residential treatment was. And there are a lot of things that go under that umbrella of residential treatment and a lot of different terms. One of the concerns was that a number of children were being placed in group homes that were not clinically supported. And that they were really not family-based placements, but also not clinical interventions. And there was a belief that this was inappropriate and that it was often being overused. And there was really a sense that they wanted to create a crisis in some ways at the state level in order to compel and motivate states to come up with more family-based placements. I'm not sure that that's exactly how they would say it, but that would be my perspective. And there was some data that would suggest that there was a wide range in utilization of congregate care or group care settings. Ron Wyden's state, Oregon, was reporting a low utilization of just 4% of young people in the foster care system were being placed in some non-family based or congregate care setting. There were other states that were in excess of 30% of the young
Wow.
people.
Mhm.
And so when you have that much variety, I don't know how clean that data was, but that's what the data was that was being reported. Then it does beg the question of why can one state use such a low utilization of congregate care versus other states needing a much higher level. And they would
Mhm.
talk about the Friday afternoon placement, the child
Right.
comes into care, there's no foster home capacity. And so they just stick the child, was the term that was used, into these group homes that really are inappropriate, and that they really wanted to shift the focus, not just to family preservation, but also increased family-based placements, feeling like congregate care settings were mostly inappropriate, particularly those that didn't have more of a clinical intervention. And that really led to this discussion about defining what appropriate out-of-home care should look like, and why there was a bias to what I would say ended up looking like a very medicalized definition of a qualified residential treatment program, which looks a lot like, for those people who are really in the weeds, PRTF, or psychiatric residential treatment facility, that is funded by Medicaid.
Mhm. That's really helpful. So in terms of a perspective of medical necessity, when do you think it's appropriate to refer someone for a QRTP evaluation?
It's a great question, and it's why, in some ways, this QI role and function, I think, is so important. I'm against the idea that a child should have to fail up to the appropriate level of care.
Uh-huh.
So often the bias is, let's start them in the least restrictive setting and then have them have to work their way up to kind of prove that they would need a higher level of care. The
Mhm.
problem with that is, I was working with some children who, before they came into care, or into my care at the residential setting, had 25 placements. And the damage that was done by that many disrupted attachments was often as significant as what might have been the reason for entering into care, or what psychiatric issues they may have had, comorbid or concurrent with whatever impacts they had around neglect, trauma, or abuse that they suffered that led to them entering care. And so I believe that it really is important to have an assessment at the entry level to determine what the level of care would be, whether using a CANS instrument or some of the other level of care instruments that exist,
Mhm.
so that we can find, the least restrictive but most appropriate level of care for a child, and base it on clinical criteria and clinical need. Not necessarily diagnosis, because
Mhm.
fortunately most of the level of care instruments are diagnostically blind, but really based upon needs and strengths. So again, the CANS would be the great example of one of those level of care instruments. And they specifically wanted the quality, the QI role and function to be separate from the child welfare system and from the residential provider. And the reason was, there was a perception that they would somehow put their finger on the scale to get the kind of outcome that they might have preordained was needed or appropriate. And so that's where we came up with this idea about having somebody who is independent, but
Mhm.
also could use a structured instrument to try to then determine what is that appropriate level of care.
Right.
There was some debate about when you do that, because obviously a child who's freshly removed from a family is going to be reactive. And so we didn't want to have that be pathologized and then reinforce a higher level of care, because I
Mhm.
said, potentially you're going to have more kids going into the higher level of care that you're saying you want to avoid if
Mhm.
you're assessing them at a point in time when you would expect that they were going to be pretty reactive and might be showing problematic behaviors as a result of the removal.
Right. Right. So there's an idea that um, removing children from their families is sometimes helpful to the child, sometimes helpful to the family. When does it make sense, in your opinion, to disrupt a child or their family such that the child's no longer with their family or even in their community? Because that's a big disruption. When is that of benefit?
Well, fortunately, I don't have to make those decisions, because I think those are some of the hardest decisions that child welfare workers are faced with.
Mhm.
Um, I do think that we constantly see a pendulum swing between trying to preserve the child in their family's placement or kinship as kind of the next second best choice, and then child protection. And what I often see happen in state or county child welfare systems is there's a move towards family preservation, and then you have a child death. And then it overcorrects. And then you start seeing more removals because the system tries to become more protective. And there's been a child fatality review committee that's made recommendations that, we don't want to overcorrect every time there is a child fatality, while also ensuring, obviously, we're doing everything we possibly can to prevent those kinds of worst case outcomes. And it doesn't have to be a fatality. We know that, the trauma that young people may be experiencing that lead to the removal are obviously seriously harmful. And we now know even about the impact on brain functioning and brain development.
Right.
And it doesn't have to be, abuse. It can also be neglect. But we also want to make sure that we're not pathologizing poverty and that we're looking at the social determinants of entries into care with active discussions about the problematic child welfare to prison pipeline and the upend movement to try to really take a look at why we have such racial disparities in child welfare systems and seeing how the system inherently gets the outcome that you see because the system is biased at every entry point or every decision point along the way. So it can be a way where some more objective assessments can try to control for some of those racial biases in decision making. Unfortunately, sometimes the racial biases get baked into the assessment. And so you have to be really thoughtful, particularly around some of the use of predictive analytics that have been tried to be used to objectify decisions about removal. Mm-hmm. So I think whenever you can, I see entry into child welfare or even an alleged allegation or an allegation of abuse or neglect as a alarm bell that you're potentially identifying a family in crisis. Mm-hmm. If the allegation is supported, how can we support that family? How can we support that young person? And thinking holistically about, extended supports, kinship supports, not just removal to kinship provider, but how can kin support that family that is in crisis that might have led to the allegation or the substantiation of abuse or neglect occurring. And then I would say that only in really extreme circumstances would you want to go to a removal. And then when you do make a decision to remove, that's when I think you have to have some assessment about, all right, so the decision's been made to remove this child out of protective concerns. What is the appropriate placement? With a family-based option always being the preferred option, unless there's a clear indication that a higher level of care is warranted. And that really is the role of the QI, to make that independent, objective assessment using a standardized instrument that would then drive that decision-making. Mm-hmm. And by the way, be used again periodically to determine whether that level of care is still needed and warranted.
Right. We're having some really good discussion in the chat right now. And one of the things that's coming up is people are having a hard time sometimes distinguishing between PRTFs and QRTPs. I wonder if you could say something about that.
I'd rather not. It's really complicated. And then, I don't even want to open up, but I will, the can of worms of the IMD exclusion. So the institutions of mental disease that are excluded from Medicaid reimbursement if you go above 16 beds. So it was an effort at that time. This was really going back to the origins of Medicaid in the 1960s, where the federal government did not want to pay for state psychiatric hospitals. And so they put this IMD exclusion that got applied to young people as well, although there is a psych under 21 exception. So it gets into such weeds that I think, and I'm not the expert to talk about that. There are folks who are, like Lizette Burton, who I see is in the chat, who can opine extensively. about the QRTP and PRTF similarities and differences.
Right.
PRTFs can be funded by Medicaid. QRTPs really are meant to come from 4E funding. If I was, in a decision-making state role, I would always want to prioritize Medicaid funding whenever I could, and not using my precious 4E dollars for clinical services and clinical placements. That was part of the conversation and concern I had about some of the prevention services, which was not what I was involved in helping to create in the legislation. But, a lot of those services, frankly, should be funded by Medicaid. And so, the whole notion that you're going to take money from the high-end services that were being funded by 4E, those residential placements, and free those dollars up for children who are at risk of entering foster care, and provide services that were meant to prevent the need for entry into foster care. Why weren't those services eligible to those families through Medicaid? Now, not all of them may have been eligible because of financial cutoffs, but if they were Medicaid eligible beforehand, before they entered into foster care, those clinical services were likely eligible for Medicaid reimbursement. And so, again, they didn't ask me whether I thought this legislation should be approved or passed. I was really just trying to make the impact on access for children to residential treatment not to go away completely, like for those under 13-year-olds.
Right.
And even the 1-year limit and the 3-year limit lifetime support, federal support for foster care, I found problematic based on a number of the young people that I had the benefit of working with in my career.
One of the questions that's coming up is, what aspects of the Families First legislation are you happy with? And are there aspects that make you nervous?
Yes. It was interesting. I came from my role, and I was representing the Association of Children's Residential Centers as its president, concerned about how this legislation would impact what I felt was a significant and critical part of the service array supporting children and families. I also do a lot of systems of care work. I've been involved with Building Bridges initiative, which was meant to really connect the community-based mental health service providers with the residential service providers, because I think it was often seen as at odds with community-based systems of care. I see residential as integral to community-based systems of care. We should always be having conversations about who it best serves, what the experience looks like, minimizing problematic behavioral interventions like seclusion and restraint, or eliminating them whenever possible, concerns about overuse of psychotropic medication in those settings, disparities in who's being placed in those settings, lengths of stay. All of those things should be part of the conversation. I just didn't think it should go away completely.
Right.
I'd say one of the things that I did alert the legislators to at the time was, by just having federal support be for QRTPs, that high medicalized PRTF-like high level of care, and then community-based, home-based, family-based care, you did gut all of those group homes that I think were providing a function in the service array. Because one of the things we also want to do is have kids, if they do have to be in an out-of-home setting, having them be as close to home, as engaged with their family, in their school, their neighborhood school, their community-based school, in community-based activities. And a lot of the QRTPs, they're so highly specialized that they're in certain settings that are at distance geographically from their home and community. And so how do we create those linkages? And I think there were very creative models of care that were trying to work towards being more community-based that ended up losing the 4E funding as a result of this, high QRTP criteria, and then nothing other than family-based, and gutting that hole in between. So I think there probably could have been an opportunity to not just say these are crappy group homes, which was the word that was always used whenever group home came up.
Yeah.
It was, the adjective was always crappy.
Mhm.
To then maybe professionalizing it or thinking
Right.
about ways in which we can ensure that those weren't just placements, but actual settings where good things could happen for kids. Bringing in clinical services. I think many group homes were already doing that if they weren't integral to the model. And really defining what we wanted the best practices to be in that interim group. So, my fear was that you were going to actually drive more kids to the highest level of care inadvertently because you were removing this other segment. And I think many states have just picked up the cost for that, because Family First doesn't say that states can't have a larger, different service array. It just says that the federal government's not going to pay for it. Now that's a powerful lever because the feds support a significant portion of foster care costs, but not by any means all of it. Medicaid is typically more of a 50-50 split, but for many states, they're getting less than 50-50 and paying for most of the foster care costs, or at least more than half.
Yeah. Thanks for that answer. Before we move on, we're going to take a moment to hear a little bit more about our new partnership called eQIP.
Hi, I'm Brandon.
And hi, I'm Kendra.
We work with the Center for Innovation and Population Health, and we're really excited to be establishing the eQIP partnership.
So what is eQIP? We really see it as a community, a gathering place where helping professionals who serve as qualified individuals can come together, share, to learn, to grow.
Right. We're really thinking about how critically important the role of the QI is for effectively applying Family First legislation. QIs are independent gatekeepers helping to reduce conflict of interest and ensuring that children and families are having their needs addressed in appropriate ways.
It's such an important role.
Absolutely. The independence of the QI is critical, but it can also feel isolating.
And that can be challenging for QIs who are committed to continual growth and improvement in their work. We all best serve children and families by enhancing our own skills and knowledge. We know a lot of QIs may not have ways to do this within their own professional structures.
So enter eQIP. We want this partnership to be a space where QIs can gather to share, to learn together, to grow together. We at the IT Center, we're generating content such as YouTube events, pre-recorded videos, and much more.
But the intent is that you, as eQIP partners, will contribute as well. Start and respond to threads in our discussion boards, share pages, documents, and media content in the links and download areas. If we all share what we know, then we will all grow together.
It all starts with equippartnership.org. There you can sign up to become an eQIP partner.
We'll look at your request and you'll get an email inviting you to join our Basecamp.
Basecamp is a virtual collaborative workspace that's perfect for eQIP. We'll use it for all of the things that we just discussed, discussion threads, as well as archiving links and downloads. It also has a schedule area so that we can keep an eye on upcoming eQIP events.
We really tried to have snacks, but sadly, we haven't been able to figure that part out just quite yet.
We hope that you'll join us. Kendra and I both will be regular contributors within the eQIP partnership, and we're really excited to get started.
We hope to see you soon. Join and learn more at eqipartnership.org. The link is also available in the description of this video.
Thank you for the work that you do on behalf of children and families.
Welcome
I
back.
had to stop dancing to that music. And I would suggest mailing snacks. I think you can mail snacks.
There you go. There you go. Thanks for taking the time to watch our little video on eQIP. We're here with Dr. Christopher Bellonci, Assistant Professor at Harvard Medical School and Senior Policy Advisor at Baker Children's Center. So, Dr. Bellonci, to continue our conversation, let's talk a minute about the QI role. You said earlier, it was in our video, that this independent assessor role is pretty important. I'm wondering what your thoughts are on how someone's approach to assessment might change when they're performing the QI role.
Well, the idea is, as you know, I mentioned earlier, that there would be somebody who is trained to do a clinical assessment of strengths and needs, at the point of entry, so that rather than having to fail up to higher levels of care, if the young person has identified needs, that they're going to get placed in a setting that is able to meet those needs. And the policymakers were, I don't know how to legislate that. I was like, well, there actually are existing level of care instruments, or instruments that have been used to help guide those kind of clinical determinations around level of care. And that really became the QI function. And then again, kind of the bias was that somehow child welfare workers would have a bias towards having these kids placed at a higher level of care. Residential treatment programs would similarly have that bias. And so we wanted these folks to be independent. That was not anything I recommended. This was just something that got baked into the legislation. And, the question about what I was most concerned about or what I was happy about, I mean, it was an interesting process to see the sausage being made. And you don't get everything that you want in that. One of the other unintended consequences was the requirement for on-site nursing, which again, for more community-based providers, was deeply problematic. But that was really being pushed by the American Academy of Pediatrics. And what I was told is, they're much bigger than you. They have a louder voice than you. We're going to listen to them over you. So that's not going to get nixed. So there were a number of aspects of what was in the definition of a QRTP, but then also around this kind of need for an independent assessment. Because it cuts out the child welfare worker who is doing their own assessment around the decision about the removal, or that might be done by the child protective side, but then it gets handed over once a decision is made to the child welfare ongoing worker. But they have a lot of information, so you want to make sure that the person who's making the level of care determination, yes, objectivity is important, but so is information. And so how are they getting this information? And to John's point, how many times is the family or the child themselves going to have to tell their story? Or how does this information get collected and conveyed and queued up for the QI person to make that independent determination, ideally using some kind of a standardized level of care instrument? So there's a lot of components to that, and how that's getting rolled out in practice, I think we're still learning. And I think this initiative can be incredibly helpful to make sure that, since this is part of the legislation and part of what we have to deal with as a result of Family First, that it's done in the best interest of the child and with the best possible outcomes. It would be interesting to do a study to see how often does the recommendation of the QI person seem to correspond with positive outcomes for that young person. So if they make the determination that a QRTP is not indicated, how often does the young person end up in a QRTP within the next 6 or 12 months because they actually did need that higher level of care? Or are you overshooting? How many times are young people admitted? I don't know how you would structure that question from a research paradigm, but are you overshooting in terms of placing a child at a higher level of care that might be necessary?
I'm really struck by focusing on the independent assessor needing information. I'm glad you really said that, because oftentimes I think the independent part gets interpreted in such different ways that going to people who have information is not necessarily seen as independent, right? They sometimes see that might muddy the waters for them, but people with different levels of engagement and understanding have that information, as you said, and it's really important that be shared and be part of what the QI considers in their evaluation. of that young person. I appreciate that so much. Do you have any other advice you want to give the QIs directly today? We've got a lot of them joining us today.
Well, I think you're meant to be both a check and a balance to the system, not using higher levels of care when a lower level of care would be appropriate. But you're also an advocate for the child getting the right services at the right time for the right duration. And so it's a really important function that's meant to be separate and apart from the decisions being made by the child welfare system. And then, what feedback you're getting from the residential provider. And I think the goal is always to try to align the needs of the young person and their family with what the service system can provide. And, again, thinking of entry into foster care as a family crisis and mobilizing all of our potential supports and services in the service of that family's best functioning. And I think the QI role and the QI process can really be critical in ensuring that our young people are getting the services and supports they need, but not more than they need.
Mm-hmm. Great. Thank you so much. I know that we have some time to take questions from the audience. And so I'm going to give the audience a moment to send us some questions, because I'm sure we'd be happy to have Dr. Bellonci answer them for you. While we're waiting for them, I have another question for you.
Okay.
What elements or components of FFPSA do you see as most meaningful in the ability to positively effectuate change for children and families? Because that's ultimately what we want. So what do you think those components are?
Well, I do think, the basic premise of Family First was we'd like children to be with their families whenever possible. That's an unimpeachable goal, right? So this was why ACRC positively engaged with the Senate Finance Committee leadership in support of that overarching goal, and wanting to make sure that, like so many federal interventions, that there weren't unintended consequences, or at least to try to minimize the unintended consequences. Sometimes I think I made something that was potentially much worse, less bad. I don't know how, I feel about that, but, and my willingness to participate in this is to continue that work, to make sure now that something that was passed doesn't have these unintended consequences and works out as best as possible, knowing that there are always going to be trade-offs. I think the initiative, the idea of supporting families by making $4 available for these preservation services is a good one. I still question why some of those services couldn't have already been paid for by Medicaid or other sources, but assuming that they couldn't, then I think, using 4E as a default or a backstop to provide some of the funding to try to create an environment where that young person can stay with their family of origin is always a good one. The bias towards all things residential is bad or all things congregate care is bad, I found to be very problematic and offensive as somebody who worked in these settings and saw the tremendous positive growth and outcomes that could come from these powerful interventions, but they should not be used lightly or benignly. And, again, we should have conversations, which I always felt ACRC was completely open to, around what do they look like? How do we serve? How long do we serve? What is aftercare? I see a bunch of questions popping up about aftercare, because there was a requirement in FFPSA that there would be 6 months of aftercare. It was very ill-defined, and there wasn't a lot of language about who's going to pay for that. That was kind of left for the states to implement with their residential provider community. I think is a great opportunity. But again, part of the challenge to the aftercare argument is these residential programs are often in very geographic settings. Many of them were former orphanages, so they were in rural settings. And so how does a setting that may be in one part of the state support a child that's going back home to another part of the state? And so a lot of the ACRC member organizations, part of the reason it's changed its name to the Association of Children's Residential and Community Services, is that residential is an increasingly small part of their service array. They are providing foster care services. They may be providing community-based mental health settings. The program I worked with, we're so frustrated with some of our aftercare outcomes that we basically bought a community-based mental health clinic so we could be part of the provision of the aftercare services. And there are some interesting pilots when the provider is actually providing the aftercare, that you get much better outcomes because they know who the child is, having served them in the residential setting. They can ensure that the treatment recommendations that evolved from that intensive clinical intervention are carried over in the aftercare setting, and using a similar programmatic model. The one I'm thinking about comes from Boys Town. And the teaching family model was then embedded in the aftercare program. And they have data to show that they got much better outcomes than usual care. So I think there are opportunities. Another example is a res-wrap model. So, you've got the child placed in the residential setting. While they're still there, you're working with a wraparound team so that when the child is ready to be in a less restrictive setting, that wraparound team is kind of handing the baton. And it's a warm handoff that we know is going to be much more successful than just saying, okay, we've done this intensive work with you for 6 or 12 months, you're good enough to go. And then here, outpatient team, and often, similarly in terms of the family, so if this child isn't going back to their family of origin or a kinship placement, if they're going into a foster care placement, that foster placement is identified. The child may have just a couple of days to be introduced to that new family. And these are children who may have already had bad experiences in family-based settings, and you're expecting this to be successful. We set up the system sometimes for failure, despite what we know is going to be in their best interest for success.
Right. Here's another question. It's taking us in a slightly different direction. Some states are only using, the QI role as part of the initial referral or intake. Some states use the QI role after placement to determine ongoing need. What do you think was the intent of the law?
I definitely talked about, if you're going to go down this path of having a QI independent assessment using some kind of a standardized level of care instrument, you should also use it at those 6-month foster care reviews. Because what does the judge know? So this is a great opportunity for the QI to remain involved or get re-engaged when you're at that 6-month decision point about both whether the child stays in foster care, but also what level of care is best and most appropriate for them. So it's an opportunity to see, is the placement in the QRTP working? What's the evidence to support it? Are they ready for a step down? Because there's lots of folks that will go around saying 6 months is all you need. Well, that wasn't my experience, and I haven't seen the data to support that. So maybe 6 months is the sweet spot for some young people, but sometimes they need a longer placement. And so it is important to kind of time this, because I've seen kids stay too long. And often the reason they were staying too long, that we often got blamed as a residential provider for keeping those young people. But we were the ones saying the child's ready to be stepped down. And it was the child welfare worker who was saying, no, they're not, or I can't find a placement that's going to be able to still meet the residual needs that the child was presenting. And so I think that's very problematic, because then you start getting into a despair cycle where the young person feels like, I've done all this hard work. I feel like I'm doing better. I'm not doing the behaviors that got me here. Now, why am I still here? And that's a legitimate question that I often had a hard time answering for the young people.
Yep. We're getting close to the end here. I'm wondering if you have any last thoughts you want to share with our group today on FFPSA, QRTPs, the QI role.
Well, first, I want to thank you for creating this opportunity for the QI workforce to come together to share peer-to-peer discussions so that, FFPSA is the law of the land, for better or worse. And whatever role I played in that, I'll have to live with. But we want to make sure that it works out as best as possible for the young people and families who are impacted by the child welfare system. And I think the QI function can be critical in that. It really is the one independent person in that whole system who, the child welfare worker, I didn't have the same biases that the Senate Finance Committee had about how the child welfare worker is going to be biased to try to get these kids into QRTPs. But whether or not that's the case, I think the independent function and the kind of use of data to inform a decision about a level of care is a good one. And so I really want people to live into what we had envisioned this resource could be in really what is a family and child's worst moment. Nobody wants to see these families come apart and for these children to have to leave their families unless it's absolutely necessary to protect them from any harm. And those are, I think we have to have a lot of humility about our ability to make these kinds of decisions for other people. And having some respect for the resilience of families to come together and make sure that we're looking at why we have these racial and not just racial biases. I work with LGBTQ youth, and we have disparities in their overrepresentation in foster care and also in the higher levels of care and the longer placements and worse outcomes. So, we need to be looking at why, that's happening and thinking about tailored supports and services for those young people and their families. Family First was meant to provide an off-ramp from entry into foster care. That's admirable. We should also be measuring outcomes to make sure that we're getting the outcomes that we thought this was meant to fix. Yeah. One of the things that, keeps happening generationally is we come up with these bright ideas about how to fix a problem that we thought that existed. And, ASFA is now being questioned. So the Adoption and Safe Families Act, which, led to that clock ticking on a permanency plan within 18 months. A lot of people are feeling like that is unnecessarily causing families to or states to determine that termination of parental rights is necessary and needlessly separating kids from their families. And I'm always, reminded that when young people age out of care, if they're still in care at the time that they're aging out, typically 18, but can be older in states, where do they go? Or if they're running away from a foster home, where are they running to? They're often running to those families that we've separated them from. Right. So there's still something going on there. And I think we want to be respectful of those primary attachments whenever possible and supportive of those primary attachments. Right. That was the basis for freeing up the $40 to the preservation services. I think that was an unimpeachable goal, but with any major intervention, we should be making sure that we're not getting more unintended consequences than benefits, and that we fix the problem that we thought existed in the first place. Right.
Well, thank you so much, Dr. Bellonci, for sharing your insights with us today. And I want to thank all of you for joining us. The eQIP partnership is organized by the Center for Innovation and Population Health at the University of Kentucky and seeks to create a collaborative platform for QIs seeking support and professional development, providing opportunities for connecting, sharing, and learning from each other. If you're a QI, don't forget to sign up at eqipartnership.org to participate in networking opportunities, future live events, view pre-recorded videos, tutorials, and more. Once you join, we have a survey for you to take that will help us understand what specific supports that you need in your role. We hope to become the go-to resource for you in an ongoing forum in helping QIs become effective in their roles as advocates for the most appropriate care. I'm April Fernando from the University of Kentucky Center for Innovation and Population Health. And from all of us at the IPH Center, thank you for what you do on behalf of children and families.